It's the first time in 2 years I've been.
Yeah, because I think, you know, oh, you.
Good job. We're gonna give you one, but you wouldn't answer, so.
Position there.
Bad year.
You're helping us. Sure you
I bring a lot of energy out the flow, so maybe we gotta bring it back.
You smile.
She's like,
Thank you.
That's my.
Oh, it's loaded.
A little bag, lots of extras.
Got rid of Kathy coffee because there's some shit.
Yeah, but they have this honey.
French is yellow. We got it.
You're in my seat. I don't know, I still like it.
They're not so loud. They're loud. Makes my mouth water to think about it. Chicken and
Oh, yeah, that got taken.
and a little baby. Yes, sir. Sure, you're bright. Did I say hello? She's, guys, I like y'all's Christmas lights. I know.
The daycare lady said.
Did you check your email before you came?
I did. Did you see my? So this is how. So.
Okay. So that he made some revisions. He had some duplications. So this number may be a little bit different. So you want to make sure you check it compared to the one you used for your. He found some errors. He sent that to you that he found an error.
Well,
It's not drastic.
okay. So this all combined for the calendar year is still 33%. Is that
Correct.
right? Okay.
It's like one or two numbers or not. It's not enough to matter. But Michael's very.
So then this is helpful for me. I do want to look at this, but I also want to look at by service. Right. So,
Okay. Well, I can go tell him to group them by
So
something.
like 2033, like basically by attending, because I care with the attendings what expectations they're setting for prescribing. Does that make sense?
But this is
It's
like.
helpful. I still like it, but really the more important piece for me is like, see, like I don't know when Bailey was on this service, Desai service, right? So I care how many clausural prescriptions are being done
Right,
by.
so what we'll do is this, and then I'll tell him to also put it on something.
That's right.
Okay. But that way, if you want to know what a certain person is doing,
By
then
ward.
you can.
By ward. So in other words, I need to know between the Clalo.
Yeah, I can do that, but I'm saying like, but if we wanted to say, okay, what does so-and-so do? We'll have it both ways. Because having it this way takes a lot longer than getting it by building, so I'll have it
Yes,
both ways.
yes, I love it. By building is super helpful.
Right.
But this is helpful too because it may be that there's a resident and the way they practice is they're really aggressive with making a causal decision, and that's someone I want to hook, right? So that's helpful for me too. Like if there's someone who's an outlier in terms of those prescriptions, then
And then also the same with the LAIs.
yeah,
You know,
correct.
I mean, so, okay, all right, so I can, Michael works
Yeah.
very hard to make, he's like, we're doing that. I was
No,
like,
it's good. I need that. Tell him that I'm super helpful, but I need a sort of less detailed one too
Okay.
that groups people.
good, all right,
I've been telling you why for a long time.
What? Can you pull the door shut? Thank you. Oh. I hope you all enjoyed the parade. Got candy. Whose first parade was today? Carrie, was this your first parade? You didn't get to see it. Everyone, this is Carrie Robinson. She's a new psychiatric nurse practitioner on Building 63. She's joined us. Formerly was at UMC. We're going to continue to pull people from UMC that are good and add them to our team, as has been our practice for a while. Okay, we'll go ahead and get into it. So you all have seen this before. This is a description of where we are in the Department of Mental Health, and the title of this was setting a standard because I want to connect decisions that I've made about how we're going to proceed with a handful of things. I want to connect sort of this idea of us setting a national standard because there's some domains in which I think that's not been done. And frankly, what I'm seeing in the message boards for public mental health is, hey, how is anyone solving the problem of the fact that the mental health world is realizing that there are some folks that end up in state hospitals or need to be in intermediate level facilities or continued treatment, right? We're seeing that emerge pretty regularly. So what we're talking about here is really what we do at the tip of the spear, and that's us. All right, so you've all seen this continuum. I think if you weren't here before, did anybody look at the governor's budget recommendations? It came out just a couple weeks ago. You remember I talked about these psychiatric emergency rooms, specifically mentioned in the budget as something that is recommended to be funded. And so these are no wrong door access points. So you'll remember that community mental health centers have the ability to say no to referrals to them based on a decision about whether a patient is appropriate for their services. This is sort of a theme that I've come across in many domains. But no wrong door means that a person in crisis can come to one of these places and a sheriff can drop them off and they're cared for. These will be staffed by emergency room physicians with consultation available for psychiatric care, obviously. Probably for 16 beds, you're thinking like 10 MHTs, so nearly a 1-to-1 ratio, plus 2 security staff, plus a hardened facility, plus things you need like EKG and the ability to run labs quickly, and affiliated with an inpatient, with a dedicated emergency room and hospital. So this should defervesce emergency rooms, and this is what's been done in many states that's been beneficial to those states. And so then the community mental health centers, part of their expectation will be if a person's cleared in a crisis center, then if they're cleared in a psychiatric emergency room, then they're cleared to go to a crisis center. So part of certification will be expecting that they accept folks that have been cleared in the psychiatric emergency rooms. And then, as we've all discussed, we don't have the ability to say no, so that's acute psychiatric. And then we've built out some immediate resources, and then we'll talk a little bit about the community transition. Okay, so this is a map of where all the currently available resources in DMH are, and I'll just point to a handful of things. These aren't open yet. This will be a major relief to Dr. Jackson's team once they're open. The intermediate, this is East Mississippi State Hospital, the intermediate male beds there, you see 50. We're almost to 25 intermediate beds built out there. They're regularly accepting some of our folks. And then we're gonna make a switch between a couple buildings that'll get us to 50. These things exist, and the East Mississippi Newton campus group homes continue to expand and get staff. So we're building out this sort of continuum that all of us have known we needed. So just as an example, I'll use Dr. Jackson. So Dr. Jackson has 29 female patients here. Have you onboarded a psychiatric nurse practitioner for that yet? Is that Miss Kang? Is she here yet? No, she's now onboarding. That's super. All right, so Dr. Jackson has 29 women, and then he also cares for 25 women on the substance use service. That's 54. So he's got a resident on each of those services and 2 psychiatric nurse practitioners. And so is it possible for Dr. Jackson to also know what resources are available here, plus Kemper County Group Home, plus the clinical status of what's going on there, plus the current clinical situation here? Is it possible for him to know all those things?
No.
No, it is not possible, right? And it would be completely unreasonable to, okay, and is there any chance that the folks here that haven't opened this building yet will have any clue what Dr. Jackson's dealing with? No, okay, good. Okay, so here's how transfers between units currently go. So psychiatrist A contacts psychiatrist B about moving a patient. Now, very often it's in-house, but it also occurs regularly. Has anybody here ever referred someone to a Kemper group home? Right, so who's here heard of Kemper County group homes? They exist. Who owns them? We do. DMH owns Kemper County group homes. Okay. Anybody referred to Newton or to group? Okay, so you get it, right? So here's how it works. Psychiatrist A contacts psychiatrist B about moving a patient. As we've already established, psychiatrist A probably doesn't have a very clear picture of what is happening here, and this psychiatrist B doesn't understand what's happening here, nor do either of those folks have the whole map of where available resources are in DMH, right? We agree with that premise. Okay, so then the treatment team at the receiving service reviews patient information, and then with the approval of treatment team B, the patient may be accepted. Now, let's just, I'll pick on, we'll say Dr. Desai. So Dr. Desai brings a patient to her treatment team. This is a new patient. So historically, by the way, a transfer from an acute unit, a transferring psychiatrist is going to be tempted, if the treatment team is coming up with recommendations, the transferring psychiatrist treatment team is going to push the psychiatrist to discharge the very most stable, well-behaved patient, or sort of the guy that's probably going to be okay, but really a pain in the ass and takes a lot of effort to manage every day. Which person does psychiatrist A, the forces that be, which direction are they pushing? Patient A or patient B? Okay, always, this is a problem across domains in all of mental health. Everyone wants to disposition their pain in the ass person, even if it's to the less appropriate place. So then psychiatrist B brings in their treatment team, and this thing with the movement of patient A has occurred over decades and everywhere forever. And so the treatment team here that has to have approval, what do they, if they've got the ability to say this patient can't come, then what's the default answer? No, right? So if Dr. Desai brings her treatment team in after years of receiving extremely challenging patients, the treatment team is going to say, yes, we're going to take whoever they send us and we trust it, or they're going to say, no, this isn't going to work. What do you think? Okay. And so then usually patients aren't accepted. This is not to say Dr. Desai's service, because she accepts patients all the time to the wait list. That's right. That's a year and a half long at least. And then in the current model, the clinical director, medical director, or a clinical administrator is not involved in deciding who moves or when. And then only the treating psychiatrists in this paradigm initiate movement of complicated patients. So if I were coming up with a system, if I said, well, we're going to set a standard of care nationally on how to treat and move complicated patients, what's the probability this works? Zero, right? It's zero. This will never work, right? Unless we've got some ability to centralize movement. All right, perfect. So we'll get into, who do I aim this at? Is it ready? Okay, good. All right, so let's look at the places. Let's look at the places where we have movement barriers. All right, so if a sending person, all right, so we've got a sending psychiatrist that wants to get someone over to East Mississippi State Hospital. Dr. Jackson has a handful of people that are stable, ready to go, and says to the folks at East, under supervision of that clinical director, I've got people that are ready to go, they're stable, you can continue their current medicines, they just need a little bit longer on their medicines. Well, then they've got the ability to say no. Same with intermediate at East. So you can imagine that even if there's resources available at each of these steps along the way, Newton has their own clinical team. They can say, look, this isn't a patient that's appropriate to us. Same with the Newton campus apartment, same with Kemper, right? So all of these folks along the way can say, no, we don't feel, even if the sending psychiatrists says we feel like they're ready to go, the receiving folks say, no, that's not possible. And so then finally Dr. Jackson does get a person over to the longer term unit at East, and then that person starts having a hard time. But historically, what happens is the return policy isn't a good one, right? So you have an intermediate level bed, the person arrives, they start having a real hard time, and so then there's an effort to move them back up to an acute level of care, but because the sending and receiving people all have to agree, the folks that send them is like, look, you broke it, you bought it. Raise your hand if you've seen this go down this way. Okay, good. Okay, super. But and then you also, if we're going to go ahead and accept the paradigm that everyone gets to decide who's treated on their service, then we would say that definitely there's no way we can set up a psychiatric emergency room system where we're sending people to you. And then anybody referred an actual IDD person to one of the IDD facilities and they block it, right? I've got the ability to send someone to one of these facilities. So and then take no responsibility for it. So anybody feel like this map as it stands is going to allow the Department of Mental Health to set a national standard if what we're talking about is continued treatment for extremely high-risk people? No. Right, no. Okay, so what if you had a person whose job it was to look at the map and figure out where folks are going to be most appropriate? Well, so we've come up with a new position. This person is a clinician that reports to me and coordinates movement of high-risk patients based on clinical need, risk level, and available resources, collaborates with facility directors, so that's administrators that you're thinking about, Mr. Chastain, Dr. Crockett, the folks at North, clinical directors at North and South, and then facilitates transitions, okay? So we've got a new policy, and this we put together last week. If any two treating psychiatrists determine that a patient is appropriate to transfer, the same thing that we've always done can continue, okay? That's good, right? We want folks to identify people that are appropriate and not involve a clinical administrator or me or the clinical director. The other way folks move is me, I'm also this person, but if at some point that person becomes different, or the DMH clinical administrator can review a patient's clinical information and direct a transfer to or from any unit within DMH, okay? So it's no longer Kemper or any unit here has to accept a patient upon review. It's, I'm going to let you know that a patient is coming, much like Beau Chastain is noticed that, hey, a person's been civilly committed and they're coming, and then the receiving unit will do the best they can, and you've got me in the position of, if we're making these clinical decisions about where folks can go, if that's not working out, and we need to do something different, you also have my commitment that we're going to get that right. And so in this way, instead of reviewing a packet of papers, you're getting a patient in front of you that might do just fine and sometimes won't. And in the sometimes won't case, we get them back to where they need to be, okay? This is the... All right, so this is, she hates it. Oh, sounds so, look at that face, dude. She can't believe, okay, yeah, Sarah Leith is the DMH clinical administrator. And so we'll move from something like this to something, I don't know exactly how we get people to psychiatric units at private facilities, but I'm not so attached. This is a much cleaner version of how we move folks between services and facilitate movement, right? What fundamentally, what ends up happening, and you all have seen this, is someone isn't ready to leave. So usually folks get admitted here. This is almost all of the patients except for a small handful. Usually folks are treated and able to return to the community from here, right? This is what we're this is what we're good at. But then it gets complicated for the rest of these placements, and we've got to find a way to land folks into the places they need to be. Okay, and so then the other pieces that I think are relevant to discuss, and this is sort of a harder topic, it's sort of like, what's the job of a psychiatrist as I see it, and a resident, and then fundamentally a psychiatric nurse practitioner. One of the things that I'm good at, it's a small number, one of the things I'm good at is really boiling things down and getting simple. I have to have that, or I would have failed out of medical school. I was concerned about that for a minute, but I've got to really simplify and get to the base of things. And so I think that these are the things that psychiatrists do that's most important for them to do, and this can get overly complicated, but fundamentally it's properly diagnose and understand important clinical factors. What clinical factors do you think I care about? Safe 7, right? We've talked about that. Is Safe 7 an actual thing? Okay, good. It's convention, right? But Safe 7 is really simple. It's all of those things that connect to good or bad outcome. Not all of them. It's the things that most connect to positive or negative outcomes upon discharge, and even on an inpatient unit. So Safe 7 are the clinical factors, and then treat symptoms. Okay, and then disposition folks. So those are really as simple as it gets. We can overcomplicate thinking about inpatient treatment, but these are the things that fundamentally matter. And so then if I'm making a claim about setting a national standard, then do the people prescribing medicines engage in best practices? Is that something that's important?
Yes.
Yes, okay, good. Do we gather and adequately consider relevant information? What do I mean by relevant information? Safe 7.
Place you're gonna go as nobody there.
Yes, and Safe 7, right? That's what we're talking about. Have we considered the information that connects to best possible outcomes? And then do we disposition a person to a least restrictive resource once risk factors are adequately mitigated? So that the Safe 7 is not meant to be some pro forma, nothing gives me hives more than forms. The point of it is to help teams contemplate how they want to mitigate problems so that the person can leave the current level of supervision they're in, right? So if a person has current severe symptoms, then we need to address the current severe symptoms with usually medicines. If a person's got a substance use disorder, what are we offering now? Not when the inpatient treatment for a year is over, we're going to send them to substance use treatment. What are we offering them now to mitigate these risk factors, right? All right. So we just discussed some of this. So as a national standard in public mental health, when you think about best practices, or a standard of care, where does that come from? Where does a standard of care come from? Expert consensus, what was that?
Evidence-based medicine groups and societies.
Like what societies?
Like
APA,
organizations.
the American Psychiatric Association. Is there any, have they published practice guidelines for treatment of schizophrenia?
Yeah.
When? 21 was the last iteration, right? How many thousands of man hours, women hours, whatever, how many thousands of hours of psychopharmacology effort, of psychiatry effort, of research-backed data, how many hours do you think goes into publishing practice guidelines?
At least 7.
At least 7, good. But probably 100,000 hours conservatively, plus all the meetings to get it all. You get a bunch of psychiatrists in a room, getting them to agree even on a basic premise on the starting language is, anyway, okay, so you get it. So some of the work's already been done. And we talked about risk factor analysis for Safe 7. We've sort of talked about timelines. I'll touch on this soon, but these are the reasons, and if you actually want to look at some of the evidence, I'm happy to talk to you about this too. But these are really so straightforward as almost to not need justification, right? So like housing insecurity, like probability for readmission is higher when someone doesn't have a safe place to live, because why? It sucks to be homeless, right? And so if you're dealing with a serious mental illness, the probability you make it to your outpatient appointment when you've got to basically get your food and not freeze to death tonight, it's low, right? So all of these things just sort of don't need much explanation, so I won't get into it. UNC, University of North Carolina, has freely available a PDF copy of this if you're interested, but I just want to touch on a couple things that I'm measuring. And before I get into that exactly, so best practices do come from practice guidelines, but you want to avoid algorithmic treatment of patients, right? Please don't misunderstand anything I'm saying is to suggest we need an algorithm, but I have heard people, so this is a sort of a newer idea in psychiatry that the minimum effective antipsychotic dose during maintenance. So you think about minimal effective doses. So the old school version, do you guys still talk about chlorpromazine equivalents? Do you talk about that much, Dr. Jackson? So something like 300 milligrams per day chlorpromazine equivalent. It's probably lost some favor with the second generation medicines, but you think about a minimum effective dose at which point you're starting to touch dopamine receptors, right? So you've got medicines, you've got a minimum therapeutic dose, and there's evidence that after first break psychosis that maybe you don't need to prescribe at the minimum, that slightly less for people over a 10-year period is going to be adequate. Okay, so that's one kind of study. And then another kind, so this is from 2008, so a little bit older, but it goes into treating folks that are diagnosed with schizophrenia, schizoaffective disorder with psychosis, and it measures total milligrams per day of 10 milligrams versus 20 versus 40, and it looks at the relationship between improvement of symptoms. So which of these, number one or number two, is probably most relevant for our population? Yeah, it's number two. So I have heard people talk about number one in the context of the folks we treat here. But for number one, we're talking about people who had a psychotic break, recovered, meaning they're no longer psychotic, and are now stable in the community for a period of 10 years on this really low dose. Does that apply? Should that apply to anybody that we have on our inpatient service? No, certainly not. But what about, have any of you seen any of the evidence related to pushing on Zyprexa? I think I've seen just a couple case reports with doses between 40 and 50 milligrams a day approximating Clozaril, right? So it's like a poor man's Clozaril. But what do you think happens to guys and ladies that are on that high dose? Exactly right. I mean, at some point we see the effect sort of taper off and the side effects continue. So if you're putting someone on, but there are cases of people who can't tolerate Clozaril because it's overly sedating for them for some genetic reason we don't understand, and then we prescribe this other medicine, their psychosis completely resolves. Okay, so the point I'm making here is if you're not looking at practice guidelines, which are pretty safe if you're going to proceed according to those, and you're looking at data, you just want to be sure that you're looking at data related to the patient population you're actually talking about. All right, so does anybody disagree? Anybody who here prescribes medicine? Does anybody disagree with this? So who here takes the Prite? Who here is going to get board certified? Who here is board certified? Any of these things, if you have a question on your boards, is this the right answer to your question? Yes, it is. So what we're talking about here is clozapine initiation. So for treatment-resistant schizophrenia, right, an adequate trial of a medication is 4 to 6 weeks at a therapeutic dose, okay, with 90% adherence. So that's the minimum dose. So you could make the clinical decision that you only want to prescribe the minimum therapeutic dose. Does anyone prescribe the minimum therapeutic dose and never go beyond that? That's choice, right? You could be justified in making the move to Clozaril after 4 to 6 weeks on the minimum therapeutic dose if that's how you prescribe. But the switch trigger is 2 non-responses, distinct molecules with persistent psychosis or violence despite optimization. The recommendation is that clozapine is offered within 30 days unless contraindicated. We agree. We agree that's best practice. Does anyone disagree that what I'm describing here comports with standard of care in psychiatric prescribing? Okay. All right, so we do have some data. So like, I guess from my perspective, there's a couple approaches to being in a position like this one. One of them is complete decentralization, which means everyone has what they have in front of them. They do the best they can. There's not a lot of coordination. And that can work sort of in situations like martial law. Like if there's martial law and everyone's like, but even then you want to organize a little army to make sure there's not too much bad stuff happen. Fundamentally, if we don't have at least good data to point at and at least identifying best practices, we're already lost. So this is over the course of the last year, and the fiscal year here, so the green line is fiscal year 25, which runs from July to July. So that's 24 to 25 July, and during that time period, 25% of the people discharged from here were discharged on an LAI. And then, even though there's an overlap between the two time periods, if you look at this calendar year, it's up to 33%. So we moved up 8% in a year, moving in the right direction. Is it part of the standard of care when you send someone to community, right? Is this something CMS wants to measure? Are they on an LAI, right? So that's pretty good, right? And we're moving in the right direction also. I give credit, I think early in the residency program, Dr. Jackson spent a lot of time making sure that early career psychiatrists understood the importance of this. I saw that, and I see that we continue to aim at getting that right. And then this is Clozaril for the last year. It was, in the fiscal year, it was 1.4% of folks discharged on Clozaril, but in the last calendar year, it's up to 3 to 3.5%, so more than double the number of people discharged on Clozaril. But it's also not lost on me that we don't control what community mental health centers do, and so probably for folks returning to the community, what do you prefer as psychiatrists in this room? Clozaril or an LAI? LAI, yeah, all day long, right? Because I think probably more often than I can count, I don't have good data on this. I want it. Early in this, when I picked up this position, I thought I want notification every time a community mental health center discontinues Clozaril, but I think spotty compliance and all of the different factors we're dealing with, if we really set the bar too high for ourselves in terms of trying to get people on Clozaril, I'm not convinced Mississippi has the supports for that yet. So best practices probably in Mississippi with our patient population, available resources is LAI. I think we have gotten this part. I think we're on really good footing here. I think it's because of the work educators have done to make sure residents understand how to treat folks. I am particularly interested in how we think about people at the 90+ day mark. Okay, so part of when I'm coming up with Safe 7, you could say everyone should know every Safe 7, but the truth is, for every patient that comes in, but the truth is that's, gathering all the information and formatting it in a way that it can be shared among different prescribers and that the information is useful and relevant, all of that, you really want to reserve that for the folks that you find impossible to move. So that's why I say 90 days for Safe 7 and 1088s, right? Because of the risk profile. Okay, so I pulled inpatient data for Mississippi State Hospital, and this is for 90+ day inpatient treatment, and I didn't discriminate between pretrial and civil. So this is everyone here more than 90 days, and this is the total number of prescriptions for Clozaril. Now, okay, so let's say Dr. Smith has 8 people here more than 90 days. Should he have 8 out of 8 people on Clozaril? No, why? Okay, great. So there are absolute contraindications. Give me a couple. Yeah, great. Previous failure of Clozaril because of seizure disorder, this type of thing. Yeah, I mean, there's ways to mitigate a lot of this, but what if all 8 of those patients refuse to take medicines by mouth? Right? Could that be a reason? Yeah. Right? What if these folks? What if someone's on day 91 and mama's been hemming and hawing since day 78, but she's agreed she can get into the community mental health center, but she's got a trip with her boyfriend planned for Christmas, and then is this happening right now? Yeah. No. Is it really? Yeah.
I have a guy that proceeded on because his mom was out of town.
Yeah. Yeah. I remember working in the Duke ER, and families would bring their mentally ill relative in, and they'd be like, "We got a plane to catch." Anyway, okay. Yeah. Anyway, so it's definitely these numbers are not Tom Recore suggesting that everyone needs Clauserville that's beyond 90 days. It is absolutely possible that all of the folks that are here for those reasons, there could be social reasons for 3. 2 of those folks are waiting on a nursing home. 3 of those folks are actually not seriously mentally ill, but they're very IDD and they're not even aggressive. And so it would be malpractice to treat them. I understand all of that, but these are factors that we want to look at, and I just bring up the sort of quick turnover beds, and I'm thinking 45-day length of stay. We're really good at getting energized about folks in their first 30 days of treatment. They're throwing feces, they're talking to themselves, they're pacing, and we go, we gotta address this, right? And then we get to some period of time, and we go, okay, this is way better. No smearing feces, no assaulting people, not talking to themselves. But then when we spend time with them, even over some weeks or months, we end up keeping medicines the same as they were when they stopped throwing all these terrible things. We end up sort of staying the same and never moving to the next step for optimization. Who has seen that to be true? Right. This is because it's a new premise, right? So this is what I'm attempting to speak to here, right? We're talking about continued treatment of folks and what it is they need and how to optimize their treatment. You know, a lot of times the conversation ends up being, we think this is as good as he's going to get. We think this is as good as she's going to get. And then you say, well, how do you know? Well, this has just sort of been there. When you go, well, what other things have we tried? And we're like, well, this is how we got him. He was on this medicine. We think this is, so what I would suggest here is when we have a person for a long time and they've been transmitted between providers, this is sort of how it's helpful that Safe 7 follows folks, that we first go back to best practices, right? Have we had an adequate trial of a medicine, and does it work? And if it works, have we attempted to increase the dose to get to therapeutic effect, right? And then if that didn't work, we try a second one, okay? And this is especially true for this is definitely true for the people who are gonna stay in our system. Who controls what they get prescribed? We control what they get 24 hours a day, right? So if we haven't given them an adequate trial of an adequately dosed medicine, then why not? And then if we have, and we've done that twice, and they're still psychotic or still aggressive, then what's it time for? Clauserville, right? Okay, super. All right, and then this is the last piece I'm looking at. I want to be careful on this too. So it'd be useful to look at sort of how the idea of minimally effective antipsychotic dosage has emerged in the last 20 years. It's interesting to look at. A lot of these medicines don't readily equivalate. Is that a word? You know what I mean. They don't readily equivalate. But I am looking at whether folks are getting at least a minimum dosage of medicine, how long they're on the medicine, and sort of, I guess if we're distinguishing between the things I'm interested in and the things that I'm interested in, but there's 0% chance I'm ever going to have time to be more skilled than you all at getting this right, is before 90 days, you guys have a lot of work to do to optimize folks and get the folks that could possibly flourish in the community there, right? And then as we're making the transition between 60, 75, 90 days, now I'm becoming interested in what the risk factors are, what we've done so far, and how we're mitigating those factors. Does that make sense? Okay. And this is especially important, I think, because if someone has to answer, why are you guys keeping people longer than the rest of the country is keeping them? Don't you know everyone needs to be treated in 30 days? What are we going to say? No, we're doing something different here, right? We think it's a disservice to patients and to the community and to other stakeholders by just turning over beds every 30 days. We understand there's a cohort of patients that need more than what they get in the community, and we're going to get that right. Okay. All right, so this is I think this is the last slide, and then I want to field any questions. So you'll be receiving, you'll be noticing that Miss Leith will be communicating with you more frequently because I'm asking her to help quarterback the sort of map of folks. Really she won't be much involved in dispositioning folks. That's business as usual, but we will be continuing to focus on what's happening at East. And Mr. Chastain and I are going to East tomorrow, and then Miss Leith and I are going to Kemper. It was really interesting when I was meeting with the folks at East in the transition with the hospital director there. One of the directors there was like, we want to refer people to Kemper, but Kemper keeps saying no. And I'm like, who's in charge of Kemper? And they're like, well, they are. The person who's in charge of the place was saying, like, we can't get the so anyway, so Ms. Leith will be working with you all to help identify folks. And if you notice folks on your service are having a hard time and you think they need a higher level of care, she's the first person to contact. And then we want to be helpful with that part too. So Safe 7, there's a couple pieces there. So we want the Safe 7s on the chart. Anybody that's a 1088 or here 90 plus days should have a Safe 7 on the chart. Residents, you can be helpful with that, and we'll look at sort of where we're at with that on January 5th. I think if folks got really motivated, they could get the Safe 7s done for this whole population, but it may be hard for some. What residents on building 45, 46 right now?
I don't have anyone on 40. Winters is
45, perfect. Just assign all of them. Just be like, look, this is gonna be late nights. Okay, super. And then perfect.
We already did it last month.
Perfect. And then, prescribe and disposition folks in accordance with best practices and DMH guidance. Fundamentally, I say the word clause rule a lot of times, but I'm fundamentally talking about how do we, when we've got, like there's all these factors we can't control. When we discharge someone to a tumultuous home life and all of that, it's like we can't control all of that. Well, we control everything that happens for our inpatients and everyone in the continuum, right? We control that. And so I'm particularly, I think there's a lot of factors that we can't account for once people leave. But for our inpatients, the things we can account for, specifically as it relates to people in this room, are how do we prescribe? Are we prescribing within accordance with best practices? And are we continuing to optimize medicines for folks? And then the last piece is, I think we've gone through a couple iterations of how to think about F1s, F2s, F3s. And I think the place I've landed is that if someone's an F1 and they need a TAP, then we'll notify you on the front end. What that's attempting to prevent is someone who murdered their neighbor from getting discharged back to a jail without a coherent discharge plan. Has that happened in DMH? A lot of times, and the reason provided is that they reach maximum hospital benefits. Like, well, they can't be tried on this murder charge, so I think the community is unhappy with us. And when I go to the sheriff's conference, they get really okay, yeah. And so no, for any case in which a person's not an F1, so F2, F3, so it's either F1 or not, right? For any person who's a civil commitment 1088, you don't have to have a TAP. You do have to have a Safe 7, and then anyone involved in the discharge planning should expect to testify if called upon to do so, if a judge has questions about how did we mitigate risk factors adequately. Okay, so what I just mean, you're not on the hook as a psychiatrist if you have a TAP, and Dr. Gugliano, who's used to getting picked over in court, is part of the decision-making for discharge, then she'll join you in testimony if called upon to do so. Same with any of the other forensic evaluators that are used to dealing with lawyers in court. And
We just volunteered me to testify for
Right. Yeah, perfect, right? And so you and Dr. Jackson together, if that were necessary, would be a dunk, right? Because you do this all the time and he's a clinical expert, right? You have a safe 7, this is how we thought about things, this is how we mitigated the risk factors, Judge. We think this person's ready to go to the community. If we kept everyone that came in that had some high risk factors, then we would never be able to take anyone new. And Judge, by the way, with House Bill 1088, you've got the ability to get a person back to the hospital immediately, and including with just an affidavit, right? Just an affidavit saying this isn't working. The community mental health center says this person's not coming to their appointment. They're not getting the LAI. All of this fits in ways we can be useful to stakeholders. But I want folks to understand, and this is sort of, you guys remember the leadership series where I talked about the triangulation, like the victim and the persecutor and the rescuer. What do you guys end up usually becoming? Rescuer. So what happens when a judge calls and says, hey, I don't understand what you guys are doing? I get tempted to what? No, rescuer. I want to save everybody from, right? So yeah, sometimes the victim, right? So I just want to make sure I place the responsibility for the decision making and the justification where it belongs. So you've got the supportive TAP. If you want it for anyone who's a regular civil admission or a 1088, great. You don't have to use it unless it's an F1, right? And so I just want folks to be prepared. It might be useful to just have residents do all the discharges, and then they could get used to testifying as well as part of their, as part of just call them all junior attendings and be like, hey, come here, this guy's out of his damn mind. It's true, it's true. Okay, all right, so that's all I've got. Just logistically, so Amy's, I'm open to any other ways to do this. Amy's team is gonna be checking the chart for presence of the safe 7s. Brianna, where are you? Brianna Singleton. Brianna Singleton is helping us with sort of the map of where folks are, the 1088 and high risk people, where they are and where they could move to, and so my best sense of how this could work is she'll create a SharePoint location. Who here uses SharePoint? Here, you got the residents do, right, at least? So a SharePoint location where by unit we have the safe 7s located, including the ones at East and North and all of that. So the folks that get disposition to Newton and all that, she'll maintain those folks when they move, and we can, yes?
I would suggest it being a OneDrive instead of a SharePoint.
That's what,
other facilities use OneDrive.
that's what I said.
Yeah.
So do a OneDrive, do a OneDrive folder. Yeah, great, thank you.
I will say forensic services has had some issues with OneDrive, and it's not, even if it's like between 2 MSH accounts.
So here's the point, is that we'll send the safe 7s to her, and then she'll get them where they need to be. And then what I want is for everyone to have access to all the safe 7s, to be able to look at, if Dr. Chin hasn't rotated on 45 yet, wants to see patients, then he can go take a look at the safe 7s. And I also don't want a situation where, I don't know, I can't think of anyone. Pretend Dr. Gugliano is a resident and she's mad about how Dr. Norton treated her. She could just go, I'm not gonna let her have access to delete all the safe 7s, and they're gone forever after all this work. So just gonna be a couple people managing those. Okay.
They do that to you.
I know. All right, so that's what this questions is for real. I need to be challenged on some of these things, and I want to be. So, Dr. Norton.
Just really quickly, because I see the adverse effects of clozapine. Great drug, but I'm 60. And not here today, thankfully. But I know you guys are starting to do serial troponins. I didn't know if you had any thought about whether that should be system throughout this.
Yeah, I'm not. I don't know that there's great evidence to do serial troponins.
Forensics, or you guys, there's that misinformation.
So people have done them in the past.
I don't know the literature. Dr. Jackson probably would.
Do you have any thoughts on serial troponins? I don't know what you would do with it, frankly. I mean, if it's great if someone's having an MI, but in the absence of an MI, there have been people order them. Dr. Perkins feels pretty strongly one way about it, which is don't order the damn troponins. So to whatever extent we're...
I was misinformed. I thought you guys were doing this earlier. Okay, good.
Am I right?
In the beginning, it was ordered. They are right now, but Dr.
So previous guidance that you received was to order them, but Dr. Perkins feels pretty strongly about not ordering them.
And so to check for symptomology.
Okay, great.
That makes sense.
Yeah, I'm not a believer that I mean, I don't know what you would do if someone's troponin goes from 0.01 to 0.03 and they're on Clozaril any given day and they're not symptomatic. It doesn't make any sense to do something with that. So, yeah. Anything else? Any questions? Please, Dr. Jackson.
Got a lot of ladies over there with SANS.
Scared needle syndrome.
Has there been any thought to getting the POC
Positive test with a finger stick. I think that's a big barrier against some of the ladies.
Bam!
actually going through with letting for out?
I mean, I'll put you in.
Yeah, the question, Mr. Chastain, was point of care clozapine tests. Let me work on that today. That's a great question. I know we were looking at it earlier and looked at the cost, but I think in terms of if you think of how much it costs, anybody know what it costs for a patient to be here for a month, roughly? $10,000 a month, right? So I don't know how much a POC clozapine thing is, but
Rent the equipment and then you buy the test strips.
Is that right?
Is one of the companies that I looked at.
Okay.
I think the strips are like $20, $25 a piece.
Okay, let me run that to ground today, and we'll look at some options and see what's cost effective. I mean, you can get, so the blood draw is the problematic thing. So
It stops a lot of our ladies from being interested in reading.
yeah, we should, this is easy. Great, thank you for that, Dr. Jackson.
I've been, when I was on your service, Dr. Jackson, in July, I talked with pharmacists or at the lab, and they said there's a way they can convert their machine to run it, but the supplies to gather the finger stick draw expire. And essentially there is a theoretical way for us to do it with what we have here. But the supplies expired and they cost a lot. No one was using them now, so they kind of don't have them at this point. But theoretically, it's possible, is what I was told in July.
So
require extra cost.
I mean, to your point, we could do POC for everyone on Clozaril and just stop with the lab draws if we had the material, right? Yeah, that's worth digging into. I'll have an answer for you guys by the end of the month, one way or the other.
Yes.
Thank you.
We can do that in our lab as far as point of care, but supplies have been an issue. Our equipment will process point of care.
Who would be the expert on exactly how this could get done and what it would cost?
Jennifer Diaz is the director of the lab.
Okay.
We can work on that with her.
Okay. Does anybody have a line to the hospital director?
I don't know that.
He's hiding back there. Okay. First of all, I don't know if this has been put out for public consumption, but about a week ago, Mr. Chastain became a granddaddy to a little girl for the first time. So. Remind us her name, Mr. C. Vera Francis, a beautiful name too. He looks older and more dignified as a result of becoming a grandpa in the last week, isn't he? Okay, any other questions? Thank you all these are really fantastic questions. Yes, sir.
Have you heard from like legislatures, or is there any kind of pushback or concern about how the transferring within the system is going to affect at all the civil commitment process, or is that untouched because we're keeping them in DMH and just kind of moving them to tiers of severity or acuity?
Yeah, the gist here is that we haven't filled yet with the really high-risk people, right? So there continues to be, I mean, one of the fundamental challenges is that at East Mississippi State Hospital, we had vacancies. And so there was a period of time where beds were allegedly paid for, but we didn't have staff, and so there was all these closed units. So it's sort of, I mean, with some leadership changes and some really elbow grease from the folks here, we've been able to open those resources. So we're still seeing wait lists to come in here. I think there's one lady and 2 men right now waiting to come in, and those beds turn over quickly enough that we're still seeing access. Where you're going to see the challenge is when all of these resources get full and we fill Newton and everything is sort of completely optimized and we get more gridlocked than we are, and then it gets past the holiday season one year and there's 20 people waiting across the state to come in here, and there's 30 crisis beds available. Then they're going to say, we can't get people into the state hospital, and we'll say, right. And so what I told the folks at the Community Mental Health, the MHIDD conference is, and I told the sheriffs, by the way, last week, if you don't have a good working relationship with the executive director at your community mental health center, you better start, because we are taking the highest risk, most difficult to place folks, and they're going to stay with us until they're ready and have a disposition plan that makes sense. So there hasn't, I mean, these ideas, when I talk about them, people are like, yeah, no, that sounds great. But in reality, when it really takes formation in its final form, when we get more gridlocked, it could be that they go, wait a minute, you're doing all these things and it's causing a wait time. And what I would say is like, oh yeah, it's a good point. So we need more beds like at Newton, and we need more beds like at Kemper County. Because in truth, that's what we need, right? Once our folks are adequately treated, they very often are able to make that transition. And when that transition doesn't work out and they come back, is there someone else ready to make the transition? Yes or no?
The legislature likes about that is those are the least expensive beds to operate.
Right. So the point that I'm making here is you don't need to build another maximum security building. What we need is placements in the community for folks to be safe. And this is a philosophical rant, but I think psychiatry has been conscripted into doing things that are not in our patient's best interest, and we've become accustomed to it. So what I would ask you, have you discharged people to the community that you were like, this is not good? How often? You do it so often you're numb, but it's a harm, right? We send people back that clearly can't take care of themselves. It's not going to work out, sometimes to a shelter. For Christ's sake, we're either going to get this right or I'm not doing it, right? And so that means that when someone comes and looks under the hood and says, why do you have all these people here? I go, well, you want to bring a clinician in to look at why they're here. I've got documentation here that we think about this every year. By the way, the Safe 7 isn't a one-off document. It takes the place of the data we used to have in our annual progress notes, right? So that is how we're thinking about folks. We obviously have expert clinicians prescribing medicines, and conceptually, it's a new framework in Mississippi. Texas just reached out and they're like, okay, we need to know how you guys run your intermediate beds, and no one's responding. It's like, yeah, we're gonna do this, and then we'll let everyone know this is how it's done. Anything else for me?
The Safe 7 repository of information, will that be an upload of a PDF of the actual form, or more of a database with fields and searchable?
It'll be forms per patient. So like let's say Mr. Smith is on your service. It's a Safe 7. You've built out a Word document that's got the description of his risk factors and what that's about. You would send that to Brianna Singleton, right? And then she would put it into the OneDrive, and everyone would have the ability to view it or download it, but not upload or delete it.
So we have the actual piece of paper that says domain and all the stuff on it. We have those for all of our guys on 45,
Perfect.
but, you know, we wrote their name at the top. We didn't put a sticker on it. So that's what I'm saying. So is that a sufficient
Yes.
compilation of
No,
information?
you're talking about the one where you just check absent, present, or
Yeah,
whatever.
yeah.
Like you're.
Oh, time out. So Safe 7 is not a form. So violence isn't present or absent. Here's an example. So let's say Tom Recore believes his neighbor is shooting X-rays at his house. And so I do something to my neighbor violent. Now, the Safe 7 form could say history of violence, yes. Or in the narrative format, the Mr. Smith narrative that I sent out, it could say history of violence, yes, Tom Recore attacked his neighbor. It could also say, okay, history of violence. On December 17th, 2022, Tom Recore, believing that his neighbor was shooting X-rays at his house, waited behind a bush for his neighbor to arrive home from a Christmas party. When he arrived, Tom got a poker that was heated in his fireplace and mashed it into his neighbor's face, causing severe disfiguring scars. After completing this, Tom murdered the dog and then went inside the house and attempted to set fire and was screaming, looking for the X-ray device. Okay. Tom also has a history of, when being admitted to inpatient psychiatric services, of being particularly sexually inappropriate with female staff members. And okay, so that's a Safe 7 presentation. Check marks and names at the top is nothing, is worthless. So that's what I mean when I say this is not a form, it's not a pro forma. What we're doing is sharing information so that we can make good clinical decisions about how to address what the person's actual issues are in time with medicines and other treatments. Does that make sense?
Do a brief summary in a Word document for each one.
Correct.
In other words.
Correct, yep.
Put their label on it.
Yes, absolutely, yep.
And if you know someone has a forensic history and you don't have access to like the forensic reports or things like, or the discovery for the alleged offense, let me know, I can get you access to that.
Cool, thank you.
For all of them, yep. Information, it used to be this siloed information silliness. If there's ever anything, if a person has a forensic something and you don't have what you think you need and you want more information, it's extremely helpful to look at that.
It is.
And so I want you to have all that.
And we don't often include details of we've changed how we do forensic reports over the time. So it used to be very detailed information in our forensic evaluation report about the alleged offense. That is not the case anymore. So you'll probably I can give you like the police report. I won't make you look at I won't send you all the discovery. You don't have to see the stuff that we see as evaluators,
Yeah.
but, I can send you the police reports and stuff, so you're not seeing photos or videos of
Yep.
dead
Okay.
bodies and stuff.
Anything else for this group?
Thank you.
As always, thank you all. And do we have one more of these before Christmas? One more, what's today, the 12th?
Today's the 9th, so.
Yeah, let me finish. So next week is the 16th.
And then the 23rd is the following week.
Okay, one more next week, but not on the 23rd. Okay, so this is the last one for December. And
What about December 30th?
nope, not that either. Next week's the last one for December. I'll let you guys know who that person will be. Thank you all.
Thank you.